Bismillahirrahmanirrahim. Thank you so much for inviting me to talk on tracheostomy, which is one of our favorite topics, being a ENT surgeon or a head and neck surgeon. And we get to see a lot of complications associated with tracheostomies as well. And that's why it's very dear to us. And we like to talk about it and impart wisdom as much as we can. So, in the introduction, you mentioned all the indications about tracheostomies. So what I thought I would do is I will go through the indications, what is the anatomy, what surgery do we do, and what are the complications related to it. So disclosure, you can read. We have got no conflict of interest here. So what is a tracheostomy? It's an opening you make in trachea for the purpose of ventilation. So we all know the trachea is our windpipe, which is an element which brings the air from your mouth to your lungs or from your lungs to your mouth. So it's this is a tube there. So if there is a problem of that tube connection on one side, then we make a hole to do ventilation. Now, if you look at this anatomy, and if you look at this picture, you'll see the trachea sits in the front. This is the front. The bottom bit is the front. The top bit is the back. And if you look, it's very much in front, the trachea. But if you look closely, you can see these blue things very nearby. These are the veins. These are our anterior jugular veins. And then you look, there's thyroid nearby as well. And the thyroid has got small veins as well. So although it's very much anterior and it looks very easy, but you can get a lot of bleeding during the procedure or even afterwards as well. Now, this is a sagittal view. And if you look at the sagittal view, again, you can see that this is the front. The left side is the front. The right side is the posterior bit. And you can see that you can see the trachea and the thyroid sits in front. Now, if you look closely, you'll see this is a thyroid cartilage. This is a cricoid cartilage. And below that, the tracheal ring starts. So we usually make a hole in the second tracheal ring. And I'll go through why we do that as well. So what are the indications? As you mentioned, bypassing upper airway obstruction to assist in long-term ventilation for low respiratory tract toilet or clearing the secretions, to decrease the effects of aspiration. There are people like Parkinson's patients. We do elective tracheostomies. Sometimes in children with cerebral palsies, we do tracheostomy so that they don't aspirate. And I usually do sometimes as a part of my second procedure where I am doing a head and neck resection and I know the patient will have an upper airway obstruction for some reason for a few days. So I put a tracheostomy tube in for 3-4 days and then we take it out. So this is a normal larynx. If you look at it in the, with your fiber optic scope. And if you can see the both vocal cords there and the whole. This is the glottic, and below this is your windpipe. Now, for some reason, this area is blocked, then you have to put the tube into the trachea. Now, it could be an early subglottic stenosis or anterior mucosal injury. This could be after ingestion of acid or having a tracheostomy or an ETT tube for a long time. And you can see the granulation tissue, and it's in the subglottic area. This is your cords. So these are one of those indications where we put tracheostomy tubes in. Or you can have a large late subglottic stenosis. Or you can see how tight it is. These are the ones usually we have to do a tracheal reconstruction on them afterwards. You can have a laryngeal rupture or injury. This could be intubation injury as well, or it could be due to any other cause. And again, these people would have fixed vocal cords. They won't be able to breathe. So we put tracheostomy to bypass. You can have infections around that area. This is a typical appearance of a epiglottitis. And you can see the epiglottis is all swollen. You can't intubate these people. So these would require tracheostomy, surgical airway straight away. You can have other infections like papillomatosis. Although we try to discourage tracheostomies in papillomatosis because it causes more trauma to the lining of the trachea and can cause more implantation of these papillomatosis, but sometimes it becomes essential. Cancers are our major bulk. We see them in ERs, patients come in with large cancers, unable to breathe, and we sometimes have to put tracheostomy there and then in the emergency department for these patients. You can have conditions like mangiomas, cystic hygromas, who can go into the in the airway and can obstruct, and you would require tracheostomy there. Vocal cord paralysis, it could be traumatic, iatrogenic, idiopathic, multiple causes. Again, you can see both vocal cords are closed. Nobody would be able to breathe through these. So these are pretty much the indications why we do tracheostomies. When I get a consult or I'm called for a tracheostomy, I have to look at a few things as well. First of all, why we are doing it and what is the level of obstruction. Would my tracheostomy help, or would I be going through the obstruction? Then anatomy of the neck is very important, because sometimes if you can't extend the neck, or patient has multiple trauma, or for instance, there is a trauma to the face or to the neck where you won't be able to extend the neck, it becomes a bit difficult. Then coagulopathy, whether the patient is on any blood thinners, general status of the patient, and lastly, a big thyroid. In our part of the country or in the world, we see large thyroids. So sometimes we have to look for that as well, and so that we can plan accordingly. How do we do it? So I'll go through the step per procedure, and it's just for your information. I'm sure we won't ask you guys to do it. So we make an incision to the skin crease. You can see in the picture, we ligate the both anterior jugular veins. The way we do it is we find our thyroid prominence, cricoid prominence, and we go slightly between the cricoid and your halfway between the cricoid and your sternal notch, and we make a cut. You can see the markings there. There's a cut, and you can see we're tying off the vessels. Then we split the straps and we lateralize them. You can see they have been lateralized there. Then we find the thyroid and we retract the thyroid and we divide the thyroid as well. You can see we're putting a tube around it and we're dividing the thyroid here. And its thyroid is divided. You can see between the clamps there, and you can see the trachea, white glistening trachea underneath it. Looks so easy, isn't it? And you can put the tube straight in. This is again ties, and tracheal window is made here. You can see the tracheal window. In this picture, they're making a yoke flap, which we usually don't do. We just make a window, and we put the appropriate size ET tube in. Sorry, tracheostomy tube in. Now, sometimes you have to do a low tracheostomy if there's a large tumor or any reason why we can't access the top rings. Now, we have to be careful that if we go below 4 tracheal ring, then your tube can sit on the carina and can go into the one bronchus, and it will affect the ventilation. And the second is when you start going low, the distance between the skin and the trachea starts to increase, and the chances of having bleeding and more problems and afterwards having a false track becomes higher as well. Then sometimes you do high tracheostomies. For instance, I'm operating on a patient today who I'm doing a laryngectomy, and this patient had an emergency tracheostomy for upper airway obstruction. So this patient, we did a high tracheostomy so that we can do a laryngectomy on him later on. So these ones, we try again not to go above second ring because it can cause subglottic edema, chondritis, and subglottic stenosis. But this patient, I knew that I would be taking out his larynx, so it didn't matter. So I went in just below the cricoid. Then there is percutaneous tracheostomies, which I feel they're easy to perform, provided you have selected the cases right. It's a shorter operating time. You can do it bedside, lower expense to the patient. You don't have to transport the patient to OR. And it's very simple. You find the trachea, you put a needle through, and you pass a guide wire. You check the position with the bronchoscope, and then you do serial dilatation, and the tracheostomy is passed. And there's a kit available for it, in which with the kit you can do it very easily. Now, in children, tracheostomies are slightly more challenging because the consistency of your carotids are the same as your trachea. So you can well imagine there are 3 white tubes, almost the same size, and you have to choose one to put the tube in. And if you miss it and you put in the wrong one, you'll lose the game there. So that's one thing we have to be careful. And secondly, in children, we have to make sure that we secure the tube tight. Otherwise, if it comes out in children, it becomes a bit difficult to put it back in. You have to do emergency tracheostomies as well. And there are a number of times where you have to do emergency tracheostomies. Um, Again, vertical incision, because we know there's, if you do a vertical incision, we are not worried about anterior jugulars, and we can go straight in, straight find the area and put the tube in. Post-operative care, because we will relieve the sudden airway obstruction, these people can go into having pulmonary edema. So we have to keep that in mind for the people who have got respiratory tract obstruction. And humidification is very important. What I tell my patients is the nose is meant to humidify and filter. And if you are bypassing the nose, then you should have something which should do the same job. So I usually advise them to have this bib, which they can, wet it and put in front of the tracheostomy tube, and it helps with that. Has it, bleeding is one of the ones which we are worried about. And second is injury to the laryngeal nerve. Sometimes you can even have pneumothorax after doing tracheostomies if you're doing a bit low tracheostomies. Sometimes you cannot put the tube in. You find it, but you cannot put it in. And this has happened to me, like doing tracheostomies. You thought it'll be easy. We are in theater in all controlled environment, and the tube didn't go in or it made a false track. So you have to be careful with these. The tube can come out. It can dislodge. You can have crusting, granulation around the tubes. As I said, you can end up with stenosis. Can have fistula. I've seen fistulas and tracheal stenosis after tracheostomies as well, which then becomes another problem to sort out. So things which are related to you, what are the types of tracheostomy tubes? We have cuff tubes and non-cuff tubes. And the purpose of having cuff tube is they provide a seal, and so that you can have a positive pressure ventilation and they can prevent aspiration. But the problem with the cuff tube is that it can cause necrosis and stenosis. So you have to be very careful. If you're using a cuff tube, you should have the pressure measurement gauge, or you should use a soft cuff tubes. There are foam cuff tubes available as well, which can be used. These are the pictures of cuffed and non-cuffed tubes. Then we have tubes which have got inner tube, which helps us clean them. And it's very good to have them because then it reduces the amount of suctioning we have to do, or frequency of suctioning we have to do. Then we have fenestration in the tube as well. And what it allows us to pass the air through your normal oral cavity, and patient are able to phonate. So these are the tubes we use over here. They're soft thermoplastic, they conforms to trachea, they allow voicing, they are fenestrated, and we are able to ventilate through them as well. So if you're using a fenestrated tube, it comes with an inner which doesn't have a fenestration. So we can put the inner without the fenestration for ventilation, and then after that we can change it to the inner which has the fenestration. Pediatrics, again, they're not that much variety available, but again, it's the same principle. We have to look at for the best for those children. The other ones which we don't have it here is the adjustable flange ones. If you're doing a low tracheostomy and there's a big gap, then we use adjustable flange ones. Silver Negus tubes were the old style tubes, and they are still widely used. And I still feel they are the best ones to use because they cause less granulation, less stenosis, and are easier to use and clean. Then we have Cochrane valves, which we put in with patients who have bilateral vocal cord paralysis. You can put that in so that they can, exhale and inflate. It just gives them a little bit of extra air that's needed. Speech valves we put in tracheostomy patients. Semior valves, these are one-way valves which we use for speaking. The stoma buttons are used in laryngectomy patients. So the ones we use is the fenestrated tubes with the speaking valve, and it helps. The important bit is cleaning of the tube. Regular cleaning with the inner cannula using the tracheostomy brush is advised. Suctioning should be controlled, because I feel that the more you suction, the more trauma you cause, the more trauma, the more crusting, it doesn't heal, it doesn't stop. So best thing is to measure the length of suctioning, which we have to do with the catheter, with the spare tube, so that we know how much centimeters of catheter we have to use. And then that's what we use. Changing of tube. So what we say is if it's being changed in the first 24 to 48 hours, this doctor or surgeon should be around so that if they lose the airway, there should be somebody to help. But most of the patients who are on long-term ventilation, they are easily intubatable. So the take-home message in these cases is that if the tube gets dislodged, don't try to put the tube back in yourself. Intubate the patient with the ET tube from the top and then do the tracheostomy again. Otherwise, if you start doing that, you will make a false track. Chances of losing the patient becomes quite high in there. How do we decanulate the patients? And it's very important that sometimes we have done the tracheostomy for temporary reasons and we want to decanulate them. Examination is very important. If the patient has tracheostomy for more than 6 months, it's better that we examine him under general anesthesia and make sure there's no granulation, stenosis. Otherwise, they will have problems. Then downsizing the tube sometimes help. If the patient has a size 7 or 8 tube, downsize it to 5 or 6, and then wait and see if he's having any problems. Sometimes we bring them in, we block the tube for 24 hours if he tolerates, and then we take the tube out and then put exclusive dressing. And it is very important. People ask me if we take the tube out with the hole closed in the neck. 90% of them close. And the ones who don't get closed are the ones which we don't have the tight occlusive dressings on. And it's not only the occlusive dressing you put on, you have to also tell your patients that whenever they're coughing or talking, they have to put their hands on the neck. It's an exercise for 2 weeks, but it, as I said, 90 to 95% of the tracheostomy stomas close. And that's it. Thank you so much.